We have Dr. Minu who will be speaking on what to do if you need an intact bag and intact rexis for a premium IOL. So you plan the premium IOL, you have a problem with the rexis and how to manage. Minu, please.
Good morning, ladies and gentlemen. Thank you, Dr. Srini, for this opportunity. No financial interest in this presentation. See, a mid-dilated pupil, and the pupil constricts further. You don't see the rexis margin. You need to chop. Sometimes you'll chop the rexis margin, and then you won't realize it. And towards the end, lucky me that there is no nucleus drop, but then you can see an open area here, this one. That is a open posterior capsule here, but see the continuity of the rexis here. There is a rexis tear here. That is the one which is wrapped around to the posterior capsule. This is the most dangerous thing which can happen without we realizing. So rexis runoff initially is a different thing, and during phaco is also a possibility. See, while placing the IOL, this is a femtorexis. IOL, premium IOL. You place the IOL into the capsular bag, but because of this faulty injector, it just gets shot in. And anything can happen, zonal dialysis, posterior capsule rupture, but peculiarly in this case, please notice this area. This area where the rexis was continuous, you can see that there is a discontinuity here. So this is a very small split. So it is not going to the periphery, whatever. So then you can just rotate the haptic and place it 90 degree away from that and get away with this. Hyper mature kind of cataract, and inferiorly there is a rexis tear here now during chopping. There was a fibrotic area which got one chop, one piece taken, all the rest chopped. So I stop, do not proceed. I don't proceed. And prolapse this nucleus out of the bag, go to a different location, or even if you want, you can extend the same incision posteriorly onto the sclera. But I decide to go superiorly and make a clear, nice, well-made sclerocorneal incision which will close well, dial the whole lens out of the bag. And the good thing is that it is not completely chopped. So it will come out in one piece, but there are different partially cut pieces. So it may come out bits and pieces. So use a lot of viscoelastic viscoat or other dispersive OVD so that you don't hurt the endothelium, and then bring out the whole nucleus cleanly. So don't be stingy on the incisions which you make on sclerocornea. They don't induce too much of astigmatism if done well. And endothelium is more crucial. And now you can see the inferior extension of the rexis here. Here again, a single piece lens can be placed horizontally. Only thing is the open end should not be close to this. Then it pops out. So the haptic optic junction on this side can be closer to this, but the open end, I keep it away from this as much as possible. So in a multifocal also, this can be done. And if you aspirate all the visco from behind and tap the lens down, usually it stays, but it cannot be always sure. But if it's a multifocal lens, it doesn't decenter that much. But if it's a toric, then comes the problem. If it decenters, then you have a problem. Even multifocal or a trifocal, if it goes a little decentered, so it is not at all safe if you have a very wide rexis and the rexis tear. If you have a smaller rexis and one small, then it's fine. So this is a mature cataract, small pupil. See this one, 5 millimeter, 5.5 rexis. I know that this is 5.5. So unnecessarily I'm having this Varion on and this tracking on and all those. And this obscures my view there, and there is a runoff to the periphery there. There are other reasons also because of the intimiscent lens, but then these kind of, now it is gone, and you can see that the staining is also not very clear there. These are the reasons for getting a rexis tear. Now this is gone to the periphery. You cannot retrieve it now.
Recording in progress.
Pardon me? I am trying to cut on the other side and bring it back towards the extension area. But the good thing is that extension is subincisional. It mostly the pressure goes in away from your incision, and so usually doesn't extend. But then the chopping has to be very gentle, and one piece has to be taken out immediately, so that you don't create large lateral separation to exert more pressure on your rexis tear, which can access onto the posterior capsule. And the flap motility sign, you cannot see here because it is being obscured by the phaco probe. Otherwise, you can on and off look at the rexis margin. If it is everted and flapping, it means that it has not extended towards the posterior capsule. Now, because the bag is relatively free, we can emulsify the whole lens inside the bag and finish off this case. But then you should realize that it was a full tear which extended towards the periphery. And this is how the rhexis looks like now. So it is a 5.5 rhexis but open on the subincisional area. Here again a toric IOL. Now the axis of placement is 21 degrees. So 21 degrees is very close to this tear, but you can see that it is a complete tear, 5.5 rhexis, centered rhexis. So if I place it, the haptic optic junction is just away from this point of tear, and the whole haptic is under the bag. So sometimes, mostly it may stay if you take off all the visco from behind the lens, tap it down to position, wait for at least 15-20 seconds for the lens to settle down, and then mostly it remains. But I have cases which have rotated just because the axis of placement was exactly at the area of the rhexis tear. So that will please be careful and have it in your mind that it may rotate. So this is the last one. This is no rhexis tear, but there is a PC rent. After placing an IOL, a toric IOL, in the axis it is there, but the PC ruptured after placing the IOL. So now this is one way you can stabilize this whole lens by, this is the importance of the sizing and the location of the rhexis margin, the size and the centration. If it is like that, you can anteriorly prolapse it, and then see, even if you inflate the anterior chamber, it doesn't release. So these two sides you can see, this is over the IOL, and these two major areas, the IOL has been brought outside the rhexis margin and it stabilizes. This is just for showing that a PC rent area can be converted into a anterior prolapse and anterior capture, so that this one stays well. This doesn't get rotated, or this doesn't go, this capture doesn't get relieved and all. So this is one way you can stabilize a toric IOL when you have a PC rent. Thank you very much.
Thank you, Minu.